Hi everyone, my name is Nick Salzman. I'm the STARS program coordinator at Cardinal Glennon Children's Hospital. We're here today to put together some training to talk through advanced directives and out-of-hospital DNR, particularly with some talking points related to our pediatric patients. I have two amazing physicians here with me and I'll let them introduce themselves.
Steve Laffey. I'm one of the emergency room physicians at Cardinal Glennon Children's Hospital, and I'm the medical director for the STARS program there.
I'm Joe Finney. I'm a pediatric emergency medicine and EMS physician and the director of EMS at St. Louis Children's Hospital.
So out-of-hospital DNR for pediatric patients in Missouri has been a challenging topic for a long time. And very fortunately, we've had some resolution with some of those challenges, but I was wondering, Dr. Laffey, if you wouldn't mind just telling us kind of the state or the history of things.
Sure. So as most of you probably know, Missouri did not really have a proper method of having pediatric out-of-hospital DNR orders. The forms that existed really didn't apply for children, and it made it very challenging for the families to have their needs and wishes met in the pre-hospital setting. That problem was recognized. It's been recognized for a while, but particularly we should give credit to Trish Casey, who's, in addition to starting the STARS program, also took this on as a mission to say we really need to do a better job of being able to comply with the wishes of the families of these children. So got together a lot of players throughout the state, very complicated system, a lot of moving parts, but over the course of several years was able to get legislation passed that gets us where we are now, which we can talk about how the out-of-hospital DNR orders can be utilized for kids.
Yeah, so I kind of want to talk through just some things that have changed because we kind of have two different moving initiatives here that have impacted this space. Trish worked very hard on getting out-of-hospital DNR to apply to pediatric patients. That is the purple form that many of us were taught and raised on here within our Missouri education. And so that was implemented in August of 2023, and that has been a valid form for the pediatric patients since then. But something else that was occurring simultaneously was a lot of work to get the TPOP and PULSed forms implemented here in Missouri as well, and that credit goes to a different group of people here within the state, particularly on the western side of the state, but also Dr. Crecelius at WashU was very heavily involved with that as well, and I want to say thank you to him. He did share his slides with us here today, so we can kind of talk through a few elements of the TPOP and PULSed as well. The TPOP PULSed form that was created for Missouri and Kansas together is now an active form in Missouri as well as of December 30th, 2024. And what you'll see as we get to some examples of this is it is a form that handles out-of-hospital DNR, but it also allows advanced directives and some more nuanced instructions for what to do for patients and their desires and their clinical care. It also applies across multiple sites, so it's not just an EMS form. It now applies to nursing homes and other situations as well. So kind of trying to get us all uniform across one set of forms that we can use. Many people, when we kind of get into the history of like why were kids not well covered under the old out-of-hospital DNR, and then also confusion about TPOP and PULSed, a lot of it came down to was EMS protected in following the form, and that's what caused a lot of the heartburn and uncertainty for a lot of years. Part of all of this new legislation is that has all been reconciled, so EMS is now completely legally protected for following advanced directives for a patient in the field, and so I want to make sure everybody's aware of that and understanding of that, and so
I think that's probably the most important. That may be the most important point that our EMS professionals take home from this is that you are, previously it was kind of like you may be protected, you may be not protected, and now if you follow it, if it's a legal document that's been signed and you follow it, you are protected under the law when you follow those advanced directives. So really, really important if you take nothing else home from this when it comes to adults and pediatrics that you are now protected to follow those instructions.
Absolutely, and that's both forms. Both forms are live and active forms, whether you're looking at an out-of-hospital DNR purple form or the TPOP PULSed form. So this is just an example of the purple form. Of course, it's in white just to keep it complicated, but that is the document that many of us are familiar with, and its limitations. It only applied in Missouri. It only addressed basically, do you start CPR or not CPR? Do you code or not code? And it really didn't allow for a lot of extra nuance. So versus the TPOP and Pulse is kind of aimed at also supportive care for end of life situations, and what does the patient want to have happen if they're just critically ill today but not without a pulse or without respirations. The top section A of the TPOP Pulse is basically what the old DNR form was. It is just go or no go. If your patient is not breathing and does not have a pulse, what do they want to have happen? So that section is entirely handled in section A of the new form, but it's section B where you get the extra instructions of they want everything outside of CPR done for them, or they only want selective treatments, or they really only want pain relief and basic comfort measures should they be critically ill that day. Section C probably does not apply as well to EMS, but for some of my community paramedics, or if you're involved in more longer term care for patients, is more related to supportive nutrition for patients over a time period. And there is also a section for just additional specific instructions that come just specific to that patient. Section E is very important, just to be aware, just like the old DNR form. It does have to be signed by both the patient and or legal guardian of the patient, and then the attending physician as well. And that's just making sure that your paperwork is actually valid there in front of you, that you are honoring.
Yeah, and so obviously not physician assistant or nurse practitioners. They can advise on those documents, but they can't sign those legal forms. So that's something you have to make sure that you check. It has to be signed by a physician in Missouri.
Yeah, and that is different in other states around Missouri and around the country. There are states that do allow advanced practice practitioners to sign these types of forms, but it's not the case in Missouri. And that becomes important from a medical legal standpoint when you're talking about forms from other states, and we can talk about that.
Some other things in there that are just useful on good documentation, just contacts to get back to pertinent emergency personnel or emergency contacts for those employees, or I'm sorry, those patients. As far as another really important point, storing these, their original is kept with the provider or the legal representative for the patient, but copies are legal, and that's really important, especially for those areas that are covered by the STARS program. It's part of what we knew about the old DNR form, but we can put photocopies of the forms in to be shared with emergency information forms. So those are valid and legal, and you're able to follow those as well. They do still recommend the practice of a vial of life if you are in a service that checks the refrigerator for that kind of information. And then, of course, in the EMRs as well for agencies or facilities that store the EMR separately. The TPOP Pulse can be modified at any time as long as the patient has capacity to make those changes and you get the appropriate signatures as well, just still making it a valid form from the physician and the legal decision maker. As Doc Laffey was alluding to, there is a slight difference nationwide between these forms and who can sign them. In some states, it can be physicians and advanced practice providers. In the case of Missouri, it is only a physician who can sign it, and therefore we only have reciprocity with states who also require it to be a physician-approved form. And so you can see the names of the other states that we have reciprocity with there. It's Alaska, Arkansas, Georgia, Indiana, New Mexico, and Kansas. So at least Arkansas and Kansas on the Missouri border, we can just directly honor their forms if that patient is here inside Missouri. It is a little more challenging if you have a patient from another state. A lot of times, there's the general belief like you're probably covered if you're following it to the best of your abilities, but for full, legal recommendations at this point, you at least probably want to call online medical control and maybe consult with them in that situation. I will speak at least for our palliative care team at Glennon, and I assume Children's would probably be willing to do the same. They are just going to get forms for both Illinois and Missouri, so that patient is just covered in both states. And so at least until we can reconcile the legal or legalities between the states, that's probably a solution you might run into in the field.
And you might talk about this too, Nick, but that's something that you really want to identify ahead of time. So, this shouldn't be something that you're surprised with in a patient population. You really should know who these patients are in your community, in your responding area. And so having that discussion ahead of time, and that's the whole point of these forums, is to get all that stuff out in front so that you're not trying to figure these things out in the moment, so that do we have both forms? What are the families, what discussion has been had with the family, and what are the expectations? So just make sure that you sort through these things ahead of time.
They have some extra resources. This slide deck from Dr. Chrysos will be included in whatever avenue we disperse the education in. And they have also given this out throughout the state, so your chief or medical officers may be aware of this already as it was dispersed throughout the EMS regions. So just to reiterate their key points on TPOP Pulse though, it's a medical order that's in effect for that patient wherever they travel to, and you now have indemnity. You can follow the form, and you are legally protected. You should check for signatures. If somebody is to hand you this form, it should be signed by a physician. And as we kind of mentioned specific to peds, it's communicating with the family beforehand, but for your adult populations, it might behoove you to go consult like high utilizers in your area, just to make sure that they're using the form. I will speak to that slightly as we kind of focus in on some pediatric considerations. And that goal is really that the goal of this should be uniformity, so that your providers are equally comfortable on, going to a nursing home versus going to a kid's home, and knowing like, okay, I get handed this form, I look for this, I look for this, and I look for this, and I know what to do with that. So that's part of the goal of all of these programs. But it would be kind of silly of me not to acknowledge that there's some pretty significant differences in pediatric world. There is a huge difference between going to a nursing home for a 90-year-old with an advanced directive and standing in a living room with a 9-month-old who's got an advanced directive. That's different for us. That's a lot of different adrenaline that we're running on. It's also different for the other participants in that care environment. So it's good to be aware of that ahead of time. It's why we kind of really want to address these issues before 4 a.m., right? Like this is a thing we need to talk about in our districts and at our agencies and at our facilities before it ever happens, so we're all kind of aware of what we're going to do. One of the very real challenges in the pediatric realm is just that it is the adult standing next to you that signed the paperwork. They're the medical decision maker. And that's a little bit different than EMS gets used to in adult world, right? Because in adult world, often the person who signed that form is the person who is in asystole before you, and unless they want to Monty Python themselves awake and tell you to work them, the situation kind of resolves itself in accordance with your patient's wishes. The challenge in the kids is just it's the parent next to you who might change their minds, or sometimes in stage doesn't always look the same to the layperson and to the parent that it does to the medical caregiver. And so it's important to understand that they may not fully appreciate that their patient is in end stage, or they may not have reconciled themselves. They may change their mind. They may say, no, never mind, I want you to do everything. And that's okay. That's EMS, we're very good at it. Just work the code and carry forth as if you would have, as if that document wasn't in place at all.
Yeah, I mean, go ahead, Steve.
Yeah, no, I think communication with the family is the key, right? That you need to make sure you're doing what they want. They're going to be in charge. We see this happen frequently. Discussions about end-of-life issues are very different when they're being held in the hospital with the family, and when reality comes and they're actually dealing with those, it's often very different than the living room. So be prepared for changes, be prepared to be flexible, because we do see that happen fairly frequently. And I think the first thing you should always do is say, hey, let's go over this. Is this still where we are? Let's make sure we're all still on the same page.
Yeah, and this is all the more reason that you need to be communicating with these families regularly, not just like a one and done check-in, but sort of regular communication, so that you develop a relationship with that family, so that when the time comes, you're not all meeting for the first time, or you haven't talked in 6 or 8 months, so that there is kind of an understanding of what's going to happen. And then you know that patient, right? You've met that patient a few times and you have an understanding of what their baseline is. And, you know, not to get off topic, but this is where the STARS program is so fantastic, is you get a expectation of how that patient's supposed to look at any given time in the STARS form. And so you want to know when you walk in that room, what's baseline for this patient and what are we dealing with now, so that you can make that adjustment sort of in the moment, as opposed to you're not really sure, you know, where they are baseline and what level of distress they're typically in. So that's all the more reason to be regularly communicating.
Well, and if I could share maybe just a little bit of stories from STARS that I think will maybe help with some of these. You know, we've kind of seen it go both ways. You know, we've had families that changed their mind and said do everything, and EMS did it and they transported. And sometimes that worked out for the better because family was able to come to the hospital where they received more resources at our pediatric facility to help them through the grief process afterwards. So for some families that can be more appropriate. We have seen a couple cases where limited measures were tried on scene, and then ultimately the decision was made to stop resuscitative efforts. But in both of those cases, it was families just wanting reassurance that the most basic or the most likely problem was addressed. A trach was changed, oxygen was applied, and CPR was tried for a little bit, and then the patient was still unfortunately in full arrest at the end of that. And family was okay and they were comfortable then, but they at least had peace of mind that it wasn't something that could have easily been fixed. And so I think you kind of can see a spectrum of calls that come at you. And the key, I think, as Doc Laffey and Doc Finney says, you know, continuous communication with that family throughout the process to see where they are and to make sure you're acting in accordance with their wishes.
I think we're hoping that these new forms, because those kind of talk, you know, the way you're discussing those cases could not have happened with just the DNR form, right? And I think that form sometimes it was hard for families to swallow. They didn't, you know, they often wanted, are you sure? Can't we just do a little? Can't we just try this? And so I think being able to customize these forms, hopefully it will make them more frequently adapted too, which is great because, you know, then when you're on the scene again, hopefully everything's been discussed ahead of time and we really are more confident that we're doing what the family really wants.
A couple of other points I just wanted to make, as we often do in our pediatric education, there are a few things that are just going to be different in kids that weren't present in your adult populations that you're more used to. But just a reminder that in some of these cases, we're dealing with really rare disease processes. We're dealing with families who are taking a kid home from a NICU and just hoping to have a few days or weeks or maybe a couple months at home with their loved one. And they want the best quality of life that they can there, but what they don't want to do is come around and come back and stay in the PICU for another few months with something that ultimately can't really be treated. And so just a reminder that there are some syndromes and disease processes out there that kind of are unique to kids that you just won't find in the adult population. We of course also have some kids who are much more in alignment with situations that you're used to in adult world, such as oncology patients or kids who have, you know, suffered a traumatic brain injury or different things along those lines. And so you can still encounter adult-like situations, but we do have some unique kid situations. And then just kind of moving forward, obviously this is a bit of adult world moving forward and us in pediatric world moving forward, but a goal that I don't think we're there yet, but I think would really behoove us as entities is to really try to get uniform. As my palliative team immediately pointed out, there's really no reason for us to use the purple form anymore. So trying to get everybody to move to a single form. And so that's a little bit incumbent on us on hospital side of the world to get everybody to go to the same thing, but then also for EMS to make sure that your protocols and your guidelines are set up to accommodate that same new change in the world so that we can all kind of be on the same page. And then it's a bit of an addition, but EMS has really evolved a lot on this front. The ability to have conversations with families in home, right? Like even 10 years ago, we were very much like, you know, if somebody coded, we just worked it all the way to the hospital and we gave them 32 rounds of epi and that's just what we did. But, you know, we've evolved a long ways towards working, but also being medically reasonable, having conversations with families inside of the homes. And I think we just want to continue to see that evolve. And I will just admit, I mean, in pediatric situations, those are some of the toughest conversations that you'll ever have. But knowing how to have that value-driven conversation with the family is so important. And not just, I'm not speaking necessarily to your values, but to their values. What was their goal for their loved one whenever they met with their palliative team or their primary physician or whoever helped them get this in place? And something else I often address a lot of times when I go out and teach on this subject, but just know that this is not a lighthearted decision that any family ever meets. Like, they usually have gone through a gamut of medical procedures and stays, and ultimately just landed on this is they want the best quality of life for their loved one and not necessarily quantity of life, and trying to find that right way forward for their family. So.
Yeah, I mean, we need to avoid, it's hard, right? Because this is a really charged situation, and we're going to have our own feelings about whether or not that patient should be resuscitated. And especially if you have little children of your own, these can be very difficult situations. And so I think, trying to keep our own perspective and opinions out of it, and know that this is something that they came to over a long period of time. And these families live very, very challenging lives as they try and navigate these complex medical conditions and situations. And so they don't come to these decisions easily, but they do come to them, and it's our job to support them through that process. One thing I would say that we should start doing more of in your agency is participating in simulated scenarios that go through who's going to have the discussion with the family, who's going to talk, because Steve and I have had these discussions with families, and I can tell you, if you're telling the 55-year-old son of the 95-year-old in the hospital that we're going to stop resuscitation, that's different than saying we're going to stop resuscitation on the 3-year-old. And so I think knowing how to communicate that to the family and knowing what you're going to say ahead of time is really, really critical, because you don't want to be fumbling for the words and trying to get your message across in that moment. You want to know what you're going to say, and you have to practice it.
Yes, I agree. And if you have any questions about that type of thing, I know Dr. Finney and myself, that's the kind of thing we would love to talk to people about. It's something that's so, you can have such an amazing impact on these families really for the rest of their lives by handling this situation properly. It truly can impact the rest of their lives. Some people will ask, well, why are they even calling us? Why are they calling me? Well, again, that end of life doesn't always look like they thought it was, or it doesn't feel like they sometimes want to have someone else there, someone that they can talk about these things with, and that you can be incredibly supportive and incredibly helpful at a time that is really, most of us can never even imagine going through it. So just realize what a responsibility, but also a privilege it is to be able to help these families through a really, really challenging time. And I'm sure you've experienced that in the adult world. I'm sure you've seen times when you felt like, yeah, we were able to make that end of life an okay, a transition that went well, and you can come out of that. A lot harder with kids and a lot more emotionally challenging for all of us, but I think you really can have a huge impact.
Yeah, whether you believe it or not, you're the medical professional on scene, and they're going to think that you are the expert in whatever is happening. So, it's important that we think about those things ahead of time, and we're prepared for that. The one other thing I want to mention is not to get into to blur lines, but we're talking about, DNRs, which are advanced directives for pediatric patients out of hospital in these forms, and not talking about termination of resuscitation. That's a totally different discussion. It's something that you will see coming up more and more in the literature as there's discussion around, how long we should be resuscitating patients on scene. Should we be doing pediatric termination resuscitation? That is not what we are discussing today. It's a completely separate topic. This is a discussion over a legal document that is identified and implemented ahead of time. So just to be clear on keeping those things separate. I mean, obviously, Steve, our institutions are always available. If anyone has any questions or concerns, you can reach out to both of our EMS outreach teams. Obviously, we're all at the same table. We all feel strongly about this, and that this is important that we implement this safely and effectively across our community. It's not a matter of personal opinion. Again, it's something that is what's decided by individual families for their individual patients and their individual children. And I think it's on us to try and make that situation as successful and positive as possible.
Yeah. I always tell, I'm talking to paramedics, you know, we're really good at this at our hospitals. I think, you know, I mean, it's something that we do on a regular basis. We have really good systems built around handling this kind of situation in end of life care because we do it frequently. So please reach out if you have questions, if you feel like we don't do this well, or I'm worried we're going to screw this up, or that's absolutely, we want to make it as good as possible. And again, as Nick said, that sometimes is a big motivator for people coming back, you know, having the kids brought and transported to either their facility or ours. It's their medical home in a lot of ways, and in medical home in a way that you almost can't comprehend the amount of time some of these kids have spent and the bonds that they have with people there. So if the feeling like, well, we're just, you know, we're transporting, why are we even doing this? Hey, that's, you may be doing it to get them to a place that they'll be surrounded by people who have known them literally their whole lives and have cared for them for years. So don't ever sell that short either. It can be really, really beneficial for the family if they do decide to be transported, because you're bringing them truly to their medical home.